Yes, so I am speaking about Alpha-1 Antitrypsin Deficiency. But before I start talking about that, I'd like to say how pleased I am to be part of this meeting tonight. I've heard great things about Rotary. Chris speaks very highly of this club and what you do internationally, so it's really lovely to see some of the faces that I hear about. So what I want to do tonight is talk about the disorder that we'll call Alpha-1 for tonight, because it's such a long name to the disorder. It's easier to call people with the disorder alphas, or you have Alpha-1. So that makes it easier for me. So hopefully you'll understand what I'm talking about when I say I'm an alpha. I'm not boasting to be the top dog. I'm just saying that I've got this disorder. So what I'm going to do is run through some of the symptoms associated with the disorder, some of the treatments, some of the challenges, and Chris has just outlined some of those challenges, and one of those is about doctors not having a good knowledge about the disorder. But I'll pick up first on one of the points that Chris made, and that is how common it is. It was considered rare until very recent years, and now it's actually considered common. So that's a huge flip from something that we thought we would never see. A lot of doctors would say they never had a patient with Alpha-1 and don't actually often learn about it. For that reason, they don't think they see the patients. But in actual fact, we know there are 1 in 9 people in Australia who will have a muted gene, and they could actually be affected. 1 in 9 is a big number, over 11% of our population. So it's quite alarming that it's actually not discussed. So one of my roles as the president of the new charity that's been set up is to raise awareness. So that's my main role tonight, is to let you know about it. If you have some of the symptoms, please go and get checked. It's very easy to get checked. So I'm going to go over to a slideshow now, and hopefully you'll be able to follow the slides along. And at the end, we'll go to questions if everyone's happy with that. So it is a common cause of disease. These are some of the key points I'm going to say a few times. That's one of them. It's a common cause of disease. So what is it exactly? It is a genetic disorder, and it's on the SERPINA1 gene. Everybody has that gene. You inherit one gene from your mum and one from your dad. And that gene makes antitrypsin. Antitrypsin has a very protective role in the body. It actually plays a protective role in keeping inflammation under control, for example, and keeping some of the white blood cells under control, called neutrophil elastase. So if you have low levels, you have a deficiency. You might have a mild deficiency, or you might have a severe deficiency. I'll explain what that means as we go along. Some of the other roles antitrypsin plays, it's like a mouse trap. It actually puts out a loop and traps protease. And there's different types of protease in the body. Neutrophil elastase is one of those, and we need to keep it in control. Everybody does. If you don't have balance in your body with antitrypsin and neutrophils, you can get disease. Antitrypsin also is an antibacterial, and you might find people who are really susceptible to colds and always seem to have a chest infection, or they might have something like Alpha-1 and they should be tested. Antitrypsin controls inflammation, and you know, aches and pains, rheumatoid arthritis, lupus, there's other autoimmune diseases that can cause inflammation. And we find that some people with Alpha-1 seem to have a high likelihood of getting these other immune diseases and inflammatory diseases. So it's actually a really funny disorder, and it can cause a lot of different problems. But the most common problems are to do with the lungs and the liver. At least 50% of those who are severely deficient will have lung emphysema, and they have it come on much earlier than people who have, say, COPD from smoking. The next most common thing that's affected is the liver, and the antitrypsin in some people can get stuck in the liver because of the mutation, and it can't leave the liver and can build up in the liver and cause cirrhosis. It can also affect the skin. There's an unusual disorder called panniculitis, where there's inflammation under the skin and you have necrotizing, can't think of the word, I suppose they're not boils, but they're bumps, and they just don't heal. You actually need the antitrypsin to have them heal. And there's an autoimmune disease associated with antitrypsin deficiency, which is a vasculitis, which is actually really serious. And if you have that, you need immediate medical attention. There's lots of other associated diseases, but the only good thing I can say at the moment is there appears to be a low risk of cardiovascular disease, but there's lots of other things that can go on. So a little bit about genes. The language is really funny with this disorder. If you have two normal genes, it's called MM, and that's just a label given because it was in the middle of the alphabet, M's in the middle, and when it was named, they thought, oh, let's call normal M. If you have one mutated gene, you might have M inherited from mum and a mutated gene called Z, which is one of the bad ones, from dad, and then you have a deficiency. Now we have over 1 million people, believe it or not, who are MZs in Australia. So that's quite common, and some of those people will never get sick, but some will get liver and lung disease. I know people who are MZs who have had a liver transplant, for example. There's different ways you can have deficiencies. You could have two mutated genes of the worst type, ZZ, or another one, SZ. So there's lots of combinations, and we know there's over 150 different types of mutations, and 50 of those are associated with disease. And there's a group called null, because they don't make any antitrypsin, or if they do make it, it actually is so damaged it doesn't actually get out into the bloodstream to protect the lungs. So the two main issues are antitrypsin can get stuck in the liver, doesn't make it out to protect the lungs, and if you get stuck in the liver, you're at high risk of liver disease, or it doesn't make it to the lungs, and then the lungs aren't protected, and you can get lung disease. So let's look at inheritance. So let's pretend this is my family. There are 4 siblings in my family. So there's a random chance that if dad had one normal gene and one deficient Z gene, and mum had the same, one normal and one deficient, then there's a probability of how the children's gene inheritance will look. You could be very lucky and have all 4 children MM, or you could be very unlucky and have all 4 children ZZ. It's truly just like a toss of a coin, totally based on probability. The genes that have antitrypsin in them, it's a co-dominant gene, so you will inherit one of these genes from each parent. And if you inherit the one that they have is that it's faulty, it's just truly based on luck. That's what I'm saying from this slide. If we look at risk by genotype, you can see the MMs again who are normal. Obviously, they're not at increased risk of emphysema or liver disease. But if you come down to the ZZs, they have a high risk of emphysema because the antitrypsin's not getting to protect the lungs. And they've got a high risk of liver disease because the Z is trapped in the liver. And it will depend on your combination, what your risk level is. There's lots of information available if you ever get a diagnosis to look up what risks are associated with your diagnosis. So why do we have all these mutated genes? Well, a lot of it goes back to the Vikings. 2,000 years ago, the Z gene mutated in the Vikings. And as you probably know, the Vikings like to travel, not always raiding. They like to go and settle in new countries. And you can see these red lines where they've traveled around Scandinavia, over to America, down to Spain, across France and Germany, up to Russia, and even down across the top of Africa. So they really did get around, and they left their genes where they went. And then with migration patterns, people coming to Australia, a lot of people came from Europe, and this is what we see across the world now. The most common ZZ mutation is popping up all around the world, and along with the other 149 types we know about, pretty much now everywhere in the world you'll find Alpha-1 deficiency. But people with your European ancestry has the highest risk. We see more coming out of Europe. Now let's look at the epidemiology in Australia. We know there's 1 in 9 people who are affected. Hopefully mostly are mildly affected. But if we look at in terms of numbers, that's over 2 million people in Australia will have at least one faulty gene. This is really amazing to me that people don't know about it when it's actually, such a common thing. We know some of these people need urgent medical attention. Some of them will have been misdiagnosed. And I found this interesting when I looked at Rotary international numbers, I looked at how many people are part of Rotary, and it looked like you had about 1 million people internationally. Well, we have more people in Australia with Alpha-1 than there are Rotarians in the world, if that data is correct. So what are some of the main problems? I mentioned the lungs. There's not enough protective antitrypsin, but the problem is it actually is a fast experience with emphysema coming on very young. It's quite different from COPD, for example, that comes from smoking. We see in very young people, aged only 35 to 40, if they're smokers or if they're vaping, they can have emphysema at that age. That's incredibly young for emphysema. In non-smokers, emphysema by the time you're 55. Again, that's very young. But the sad thing is, by age 60, only 16% of people are alive who have the ZZ genes. So it's not good, and because treatment's very poor at the moment in Australia. It's actually quite distressing. So what happens? When you smoke, the neutrophils become activated, and that allows all the antitrypsin basically to be destroyed in your lungs. So smoking is a very bad thing. It's really the key message. If you are smoking, it's best to give up, because otherwise you have rapid lung disease. The neutrophils don't stop doing their job when they've eaten all the bacteria. They actually keep eating the lung. And that's why the emphysema occurs in young people. It also damages, the neutrophils damage the elastin in the lung, which gives the support to the lung. So in between the air sacs, that is all destroyed, and you can get hyperinflated lungs and a lot of other lung problems, as well as the classic emphysema. Some people will be unlucky and might go on to get right heart failure, because COPD puts pressure on the heart. Now, some of the problems are to do with the rapid lung decline, and that can happen very quickly with bacterial lung infections such as pneumonia. So a key message from tonight is, if you know someone with Alpha-1 who has a chest infection, they must get onto antibiotics within the first few days to really stop the lung being eaten. Some other things associated with the lungs, other diseases, you might have heard about bronchiectasis, where the airways become permanently scarred and inflamed and open. And chronic bronchitis is a bit similar to bronchiectasis. This fellow here in the picture, if you can see him, he's one of the alphas in Australia. He's just had a liver transplant because he had ZZ and it had accumulated. And unfortunately, his lungs are also affected, and now he needs a double lung transplant. And a little bit about emphysema in case you don't know about it. In the normal healthy lung, you'll see down off the airways here, you have these alveoli. It's not an exotic pasta. Have you heard of alveoli before? In a normal healthy lung, you'll see these lovely round shapes. This structure is very important, because when we breathe in, the oxygen goes through the alveoli into your body, and when your gases are coming out, they've got to come out these structures. So the gas, carbon dioxide, will come out and oxygen goes in. In emphysema, that all breaks down and you can't have gas exchange go on. So it's a very serious thing. We need oxygen in the body for all of our organs. In severe cases of emphysema, you have this is bullous emphysema. See these giant bulla? These are huge. In some people, these can be 20 centimeters big in the lung. And obviously that's in the way. You can't move, probably can't breathe. But luckily, some people will have surgery and they'll survive surgery once the lung is that damaged. At least there's something on offer. I mentioned bronchiectasis. Here's an example of what a normal airway would look like. Nice, smooth walls. In bronchiectasis, you can see the airway is inflamed, bulging, and that actually scars and becomes permanently dilated. And then the mucus pools inside, and you set up this horrible cycle of bacterial infection, colonization. You have the neutrophils activated, and you can't actually cough the mucus out. The actual cilia in the airway, the little hairs, often get broken off, and you can't clear your lungs. So you need very good airway clearance techniques to stop that bad bacteria the whole cycle, the bacteria, and then the neutrophils coming along and doing the damage. But there is some treatment. The usual asthma puffers you probably know about. Some of them are bronchodilators to help you breathe. Some are steroids that can try and control inflammation. I mentioned how important it is for fast treatment with antibiotics. Now, ideally in Australia, we would have what's called the antitrypsin infusions, augmentation therapy. This treatment costs on average $100,000 per person per year for life. So clearly that's unaffordable. And at the moment, people with Alpha-1 are really just left to their own devices. This is not good enough, and it's one of the reasons why the charity's been set up, because we're advocating for treatment. We have to do something about it. We can't just let people go along with these normal treatments that aren't doing enough to maintain the lung and the liver. Lung volume reduction surgery is sometimes offered to people with COPD, but the type of genetic COPD we find in Alpha-1 isn't so good. Alphas don't do so well with that surgery. So what is offered instead are things like the Zephyr valves. This picture here shows an airway, and that's the Zephyr valve. And they put that in to block off the damaged part of the lung. So above here you would have some of that emphysema I showed you in the earlier slide. This is a one-way valve. So when you breathe in, that valve closes and the air stays in the good part of the airway. It doesn't go up to the bad part where the emphysema is. So that gives people much better breathing, and that's suitable for anyone with COPD if the emphysema isn't widely spread. If it's widely spread, they won't use it. The bullonomectomy can cut out those bad parts in the lung, the bullous I've showed you. But really at the end of the day, what's on offer is lung transplant. So that's a pretty savage, normal treatment, which we would really like to avoid. Now let's look at the diseases of the liver. I've talked about the Z mutation and how it can get stuck in the liver. What happens is all that antitrypsin is stuck and becomes a polymer. On this slide, you can see that shade of purple. Wherever that's showing, this is a real slide showing the polymer accumulated in the liver. And that's where the scarring and the cirrhosis can occur. There's a lot of inflammation that can occur, and this can start from day one. In actual fact, babies can be born with a ZZ mutation, and they are born with very bad cirrhosis, and they have to go straight to liver transplant. It's hard to believe that a baby would have to be rushed off with the polymer so much formed at that age. 10% of the ZZ babies will have bad livers, and 2% definitely will have liver failure in those first few years. The rate of liver disease in adult alphas is more like 30%, perhaps by the time they're around 50. As you get older, there's more polymer, so the risk increases as you age. Now, in terms of COVID, we think alphas will do poorly if they catch COVID because it does affect liver and lungs, and the advice is to stay home for as long as you can until an immunisation is available. Let's look at a little baby who's had Alpha-1. This is one of our Australian alpha babies. The liver isn't working. And what happens when babies are born who are double Zs? You can see that they'll have raised liver enzymes. The normal jaundice you might see in a baby goes on and on and on. It just doesn't clear up. It's a clear sign that the liver is very badly damaged from polymer. They can have portal hypertension, the portal vein going into the liver, can't get the blood into the liver, and you can get what's called ascites, where the tummy is very swollen and all the fluids leaked out into the tummy, and that will have to, have an incision to let the fluid out. You can get bleeding and terrible itching, pancreatitis, and lots of other things can go wrong. So that's not a nice state for young children in particular, not nice for adults either. So what can we do for the liver problems? Unfortunately, there's no real treatment. It's really supportive care. Ideally, you'd catch the inflammation early at the fibrosis stage before it's reached cirrhosis. If you do get a liver transplant, that's considered a cure because the new donor liver will have antitrypsin in it, and then that can go out to protect your lungs and it won't get trapped in the liver, so that's curative. But we would prefer different types of a cure because the transplant's pretty savage. There are clinical trials underway they're very clever, some of the scientists and doctors. They're trying to stop the protein in the Z mutation from misfolding. So lots of genetic therapies are being trialled, but we've been told internationally, don't expect a cure within probably 10 years. But we live in hope. Some other diseases associated with Alpha-1, paniculitis I've mentioned, the vasculitis I've mentioned. Gallstones is a funny one. Even though MZs shouldn't be affected as much as ZZs, they are at high risk, the MZs, of having gallstones. And often people in their 20s, 30s and 40s will be getting gallstones. No one really knows why, but it's a very interesting observation. And it's good to know that MZs at one level get sick, because in the past they were dismissed. Doctors often told them, you don't get sick, you're an MZ, you're only a carrier. Very misleading information. They can get sick, they can get as sick as ZZs, but usually not as often. Aneurysms and a few other things can happen, but some of these things are very rare, which is lucky. So some of the problems from an alpha perspective is that we don't have good epidemiological data. We think we know it's 1 in 9 people will have a defective gene, but it actually could be higher or it could be a little bit lower. We need to do more research. Another problem is that when babies are born, there are some genetic tests done, but unfortunately Alpha-1 is not one of those tests run because the government thinks that we'll find out about it later, there's time to do something. But unfortunately, because it's not commonly known, people aren't finding out. And people can be in the wrong occupation and be exposed. For example, if you're a firefighter and you're exposed to smoke and chemicals, you can have that damage done to your lung just by going to work. If you knew you were an alpha, you might change jobs. So there's definitely benefit in testing early. One of the real problems is the misdiagnosis. For myself, I'm an alpha, I'm a double Z, and I was diagnosed as having asthma. And so for about 7 or 8 years, I went along my normal business, taking my puffers, thinking I was doing the right thing, having no effect on my lungs really, because it was a misdiagnosis. And it's very common for COPD also to be given as a label, and that can be a misdiagnosis. And so all people with a COPD diagnosis should be tested because 3% of those will have Alpha-1. COPD, I'm assuming you've all heard of it. Chronic obstructive pulmonary disease. Here's an example of how the wrong occupation is bad for alphas. And there was a 4-year study after 9/11, after the terrorist attack, and they found that different genotypes had their lung function decline more rapidly than others. For example, they found the ZZ first responders lost their lung function 11 times faster than some other groups. That's a lot of lung function loss, and those people will have permanent damage now because they didn't know they had Alpha-1. So what's the another angle to this problem? Why aren't doctors diagnosing it and getting the right diagnosis? It's been suggested that one of the reasons is because not all doctors are trained in genetics. The young doctors now tend to be, but older doctors perhaps weren't. It's to do with also the way the emphysema presents in the lungs. It's often said that Alpha-1 has damage to the bottom of the lung. With COPD and smoking, for example, it's often at the top of the lung. So doctors are looking for this classic lung pattern of emphysema, but in actual fact, at least 30% will have emphysema in different parts of the lung. Doctors might assume that smoking and COPD go together. They're not thinking genetics. Doctors are systems-based, and they'll try to make sense of a list of symptoms. But with Alpha-1, it doesn't work because the symptoms can look very similar to asthma or bronchitis or some other diseases. So you definitely need to have the test called Alpha-1 Antitrypsin blood test and possibly some other tests as well. Some of the other problems I've mentioned that the puffers probably don't really do much. Might help a little bit with breathing, inflammation and controlling mucus. We really need augmentation therapy. The quote I was given is based on your body weight. My quote was 82,000. I had to take early retirement at age 55. There's no way I've got that money to go out and buy augmentation therapy for the rest of my life. So this is the real challenge for people, and that's why our charity is really advocating for treatment. The challenge for us is that the government said no to the submission for augmentation therapy. We know from the evidence in the literature that it works in other countries. In America, they've been using it for 30 years, and those people now have a normal life expectancy. So it's quite distressing from an Australian Alpha perspective to know that we're denied here, along with some other countries. But it's widespread in Europe, Canada, and America. But other countries like the UK, Australia, and New Zealand are all denial countries. So some of the tests you would have is the level of the antitrypsin in your blood. That's misleading if you just have that test alone, because if you're on the pill, for example, or if you have an infection, that antitrypsin level can be higher than it really is. So there's a list of other tests here you should have, including looking at your inflammation markers, the CRP. You'll have lung function tests. If you're not familiar with lung function tests, that's an example of having your lung function test looked at. They'll look at how quickly you can breathe out in 1 second. They'll look at your gas exchange. And if you are diagnosed as an alpha, there's annual monitoring for life pretty much. Your liver and lungs need to be monitored at least once a year, is the general advice. So who should be tested? Any young infant who has the ongoing jaundice. If you have early emphysema, if you've never smoked and you have emphysema, if you've got that funny diagnosis, adult asthma, all COPD patients should be tested. If you're getting the frequent lung infections, if you're having trouble breathing, if you have unexplained liver disorder, such as cirrhosis, if you suddenly develop paniculitis, or if you have a family member with Alpha-1. So here's an example of our strategic plan. This is our plan on the page for our new charity, the Alpha-1 Organisation Australia. You can see we have 4 aims: to support people who have been identified as an alpha, to focus on education and knowledge for doctors, to try to make sure that that's increased in all health professionals, actually, not just doctors. We're advocating for change, and we're raising awareness. If you go to our website, which hopefully is launched this week, our Facebook pages are up, and we are on Instagram and Twitter, but we're just finishing off the website. You'll see we're very active doing some different projects. I've just written over 10 information brochures and fact sheets that are on the website. They can be downloaded and read if you want further information. We're putting in a structure including state coordinators, so patients have someone local that they can contact for support. So it's very easy to become a member if you know someone who's been diagnosed. You can click on here, become a member, just pay a very small fee. There's some contact information. If you want to contact us, you can use that email address there. So in summary, the key points are Alpha-1 antitrypsin deficiency is common. We need to get the word out for people to be tested if they have those symptoms I've talked about, because it can result in really serious disease. We know there are things that people can do to stay healthy if they do have a diagnosis. For example, if you have a diagnosis of fatty liver, you can change your diet to try to reduce the inflammation in your liver so it doesn't progress to cirrhosis. It's a very simple blood test, and we now have this great charity that's set up to support people who are diagnosed and to advocate on their behalf for treatment. That's an example of one of my paintings I did when I was diagnosed. That's me coming out after the diagnosis, clinging onto the tree of life. Thank you, that's it.